Welcome everyone to our first top seminar of 2026. And thank you everyone for joining us today, both in person and online. Before we begin, just a quick reminder for those that are joining online, if you could please keep your microphones muted during the presentation. We will have time for questions at the end, so please either add your questions into the chat and we can read it out for you, or you can raise your hand at the end to ask your question directly. And just to note that we are recording the seminar, so if you do speak during the session, then you may be on the recording. Many of you online today have already signed up to join our mailing list to hear about future CAP seminars, but if you haven't already and you would like to be added, then either please add your email address into the chat or just send myself an email and I will add you to that mailing list. Okay, so today we are delighted to welcome Dr. Doranne Thomassen from Leiden University Medical Centre. So thank you for agreeing to talk to us today. So Doranne completed her PhD, so she defended her PhD last year at LUMC, in which she developed statistical methodologies to derive the effective sample size. And today is going to be talking to us about how she's translated this effective sample size to causal prediction setting. So without further ado, I will hand over to you, Doranne. Thank you.
Thank you very much, Becky. And yeah, thank you also very much for the invite to talk at the seminar. I'm excited to discuss sort of further development of this concept of effective sample size, especially in the direction of causal prediction modeling. That's what I will be discussing this afternoon. Before I start, I'd just like to acknowledge the team that we're working on this project, Nant Mangeloven, Daniela Weer and Marleen Kunneman, and also the financial support that we've received from the Dutch Research Council. So just first, as a bit of background, if we look at how clinical prediction models are used in practice, and then they are used for actually a variety of objectives. Sometimes they're used for diagnosis, and sometimes they are used for prognosis, for example, to manage patients' expectations or to plan resources. But clinical prediction models are also used to support individual treatment decisions. And then we get into a sort of a bit more difficult territory because the role of treatment in the development of clinical prediction models is often unclear. When we use the models for decisions, then the predicted outcomes influence treatment decisions, but the treatment decisions themselves then also affect the expected outcomes for the patients. And therefore, prediction-based treatment decisions may be misinformed and even harmful, as has been shown recently. So as a sort of solution, causal prediction has been proposed, sometimes also referred to as counterfactual prediction, which essentially means that causal inference techniques are combined with prediction modeling to predict outcomes under potential intervention options. And the reason why these causal inference techniques are sort of added onto the prediction, even though we're not necessarily estimating the effect of a treatment, but still they help us predict what would happen if a patient were given a certain intervention, which is usually estimated as the expected outcome for a specific patient profile if all such patients were to receive the intervention, instead of the expected outcome in the subgroup of patients who historically received the intervention, which is usually what we observe in our model development data. Then bringing it back to uncertainty, I think uncertainty on the level of individual predictions has historically not received that much attention. Performance evaluations were often based on the points predictions and evaluated on a sort of more population level. However, recently there has been a lot more attention to finite sample uncertainty and model stability, among others by your group at Birmingham. And I think a key aspect here is that sampling uncertainty can vary a lot between individuals, as not all profiles or types of patients are represented equally in model development. And furthermore, high individual uncertainty is not necessarily flagged by overall performance metrics. So a model may have good performance by traditional metrics, but still be very uncertain for some types of patients. And then in causal prediction, this sort of confounding adjustment step that we add on to the regular prediction can also lead to additional uncertainty in the final predictions. So yeah, this led us to think for the current project whether we could somehow quantify finite sample uncertainty in individual causal predictions. And this is not straightforward because variance estimation for causal predictions is not straightforward. I'll go into that a bit more later on. And secondly, we wondered whether we could improve the transparency of clinical decision support tools by also making this information accessible to end users of the models, meaning clinicians, patients, informal caregivers, anyone who wants to make decisions using the information from clinical prediction models. Since we developed the effective sample size to express uncertainty in regular quote-unquote predictions previously, we thought, can we extend this concept to also express uncertainty in causal predictions? So just as a bit of background, what is this effective sample size that I've been talking about? The idea is there that the sort of uncertainty or certainty in a prediction for an individual patient is expressed as a number of similar patients that this prediction is effectively based on. So more formally, if we have a patient, let's call them Sam, and we have a prediction model which we use to predict an outcome for Sam. And then we imagine we have a hypothetical sample of n patients like Sam, meaning with the same predictor profile. And we assume that we observe a sample mean equal to Sam's prediction in this hypothetical sample of patients. Then we define Sam's effective sample size as n such that the variance of the mean in this hypothetical sample is equal to the variance of Sam's prediction. And again, that's then interpreted as sort of number of similar patients. So just also to get an idea of how this type of uncertainty can play a role in decision making, because sometimes it's argued that only the point estimates are relevant for decisions. I would argue differently. So this is a very simple example. This is a map of a city in the Netherlands near where I live. And I have chosen one restaurant. Let's say you want to go for lunch, and you see this restaurant, and it has 5-star reviews. However, you can also see that this is only based on 2 reviews. And then, my question to you, of course, I cannot ask you in person, but would you trust the reviews enough to go to this restaurant? Personally, if I saw that it was only 2 reviews, I would not be sure, and I would maybe try to look for other information, maybe see if there's a website or some other way to find out whether this is even a restaurant and whether it's any good. So this is just if I have one option, but if I then have a second option, a second restaurant that I might go to, this one has 4.7 stars out of 5. So it's a little bit less than the 5 out of 5, but those 4.7 stars are based on 570 reviews. And then my question again is, which of these 2 restaurants would you choose? Of course, this is a very extreme example, but I do think that, if you have an estimate, for example, the 5-star reviews on the left, with just too much uncertainty, that you might want to take other sources of information into account in your decision. And therefore, I do think that it plays a role in decision making. Now, linking this to causal prediction modeling in a clinical setting, our final aim is something like this. So here we have a patient, we want to predict their probability of benefit or risk, or the probability of benefit or their risk under various treatment options. And these ones are linked to a case study that I will discuss later, but could be anything. And so the idea is that we have a prediction of probability of benefit in this case for each of these 4 options, and that besides just giving this probability, we also give an indication of the uncertainty of this estimate in terms of a number of patients like you or like this patient that this number was effectively based on. With that in mind, we formulated some research questions for our project. First challenge is how to actually estimate effective sample sizes for causal predictions. And then secondly, also in view of transparency, does the effective sample size also relate to the plausibility of causal inference assumptions that we're making in these causal predictions? And finally, can the sample size or its causal version help users of decision aids in their decision-making process? So in this talk, I'll mainly focus on the first 2, and the third, I'll say a little bit about it, but that's still ongoing work. So it's about to get a little bit more technical. Just to sketch the setting that we are working in, a causal prediction setting. We suppose that we have a binary outcome y that we want to predict. Then we also have a categorical treatment assignment variable denoted by A. And then we have y superscript A, denoting the potential outcome y if the treatment were set to little a. And then we have a set of variables called x, which are the variables that we are considering as predictors of this potential outcome y under treatment A. And our estimand, so that which we want to estimate in this case, is the expectation of the potential outcome y under treatment A given predictors at x. To estimate this estimand, we need to make some assumptions. Those familiar with causal inference will be familiar with them. So in this case, there are a few. The first is no interference and consistency. I'll not go into that too much. The second is conditional exchangeability or no unmeasured confounding. And for this assumption, we kind of distinguished 2 scenarios in our research. The first scenario is where the conditioning on the predictors in our model is already sufficient to ensure no unmeasured confounding, so sufficient to ensure conditional exchangeability. And the second scenario is where conditioning on X is not sufficient and we need an additional set of confounding adjustment variables, which I'll denote with L star, to ensure this no unmeasured confounding left. This additional set of confounders L star is expected to be available at model development, but the final predictions at deployment are not expected to be, or we do not want them to be conditional on L star. And this can be for various reasons, practical reasons, because maybe these variables are very difficult or expensive to measure, but also ethical reasons when the variables in L star are protected attributes. And so, yeah, translating this assumption of no unmeasured confounding into a prediction setting essentially means that conditional on X or X and L star, depending on the scenario, the outcomes in the subset of patients who received the treatment are sufficiently representative for similar individuals who could, in theory, receive the treatment. Then there's a third assumption that is important, and that one is called positivity, or sometimes called overlap. There are sort of 2 versions of this one. The first means that all patients for whom we want to predict the outcome under a treatment are actually eligible for this treatment. So in theory, they could receive the treatment. And then the second version essentially means that we also need enough data to estimate outcomes under a treatment of interest for each predictor and confounder profile that we're interested in. And then finally, often causal inference requires correct specification of some model or models. So once we're willing to make all these assumptions, then we can predict an outcome for a patient under a specific treatment. And if we were to then also give an effective sample size with this treatment, we envisage being able to communicate something like this example. So we give a patient a prediction under a certain intervention, and then we might be able to also tell them that this number is effectively based on NF people like you who had treatment A with similar predictors X. And then also we want to say something about the no unmeasured confounding assumption, but we're not sure of the best wording yet. So yeah, it would be something like the study made sure that they were comparable or balanced or representative regarding the variables in confounder set L star. So yeah, any feedback here is welcome. We're still figuring out the best way to phrase this. And so then looking back at the causal inference assumptions from the previous slide, then the effective sample size itself expresses sampling uncertainty as it does for regular prediction. But in this case, that also relates to the positivity assumption that we're making, especially the sort of non-structural version, where we're saying, do we have enough data in each sort of predictor, confounder, treatment, combination, profile to actually estimate what we want to estimate. And then explicitly mentioning the variables in X and L star may also enable a discussion on conditional exchangeability. Of course, it may depend on the type of user, whether this is desirable. Perhaps clinicians have more ideas on what would be important confounders and what would not be. But yeah, that's something that we're still figuring out. Looking at it more technically, because to be able to present this information, we first need to be able to estimate it. Previously, we showed that for binary outcome events, effective sample sizes can be estimated essentially as the variance of the predicted outcome divided by the variance of the prediction itself. And so for the numerator of that expression, we can just plug in the estimated risk, which we obtain from the prediction model. And then for the denominator, it's a little more complicated because we need an estimate of the variance of the prediction itself. And how we can obtain that depends on the modeling approach. And so far, that has been our main challenge in the methodological part of this project. Often there's no analytic solution, and a non-parametric bootstrap doesn't always work either, especially when we're using very flexible nuisance models, as these are called, because then the regularity conditions for the bootstrap to be valid do not hold. And so we cannot really trust the resulting variance estimates. So we've been working on that. And again, in that work, we distinguish these scenarios that I mentioned previously. So in the scenario that the predictors are already sufficient for exchangeability, the computation methods, if we just have a model with the predictors, then the computation method for the effective sample sizes can be the same as for regular prediction. However, the interpretation is different because treatment plays a role and uncertainty relates to this positivity assumption. In the case where the predictors are not sufficient to ensure exchangeability, we need to adjust for these additional confounders in L star during prediction model development and then average them out before deployment. Then this is a sort of confounding adjustment step, which needs to be accounted for when estimating the variance of the prediction. So we looked at various causal prediction methods. Yeah, I won't go into all the details here, but this is just to show that, yeah, we looked at a bunch of different things essentially. And both for scenario 1 with only the predictors and also for scenario 2 where additional confounders might play a role. Then for each of these causal prediction methods, we had to come up with estimators for the prediction variances. And yeah, this was easier in some cases than in others. So for all of these, we managed to come up with something. Only the bottom one, it's called the I-learner or imputation learner. We're still working on variance estimation, but for all of the above, we managed to work it out. So we applied all of these methods in a case study. And I'll first just introduce what the case study looked like. So our case study focused on patients with type 2 diabetes who had initiated a first-line oral medication called metformin. And the goal of metformin is to reduce blood glucose levels to a sufficiently low level. However, in these patients that we were considering, they had initiated metformin, but their blood glucose levels were still too high. And then there were 4 treatment options that we considered. The first was not to do anything, essentially, just keep on metformin and see what happens. And then the second, third, and fourth were all different types of add-on medications that could be added to the metformin. And what we then want to predict is for each patient, based on certain predictor variables, what is their chance that their blood glucose will be sufficiently reduced within a year after starting this add-on medication or not starting any add-on medication. For this question, we were working with CPRD data, which is a registry of general practices in the UK. We had almost 16,000 complete cases that we were working with, and we considered 6 predictor variables in set X. 4 were about the patient's current medication use, and 2 were about demographics, so age and gender. And then we specified 5 additional confounders in L star. And we chose these variables because, well, we wanted an example where L star was sort of not fully contained, or where not all the confounders were yet contained as predictors. And we imagine a scenario where maybe a patient comes to a doctor for the first time and sort of their current situation is known, but maybe not all of their medical history is known. We're sort of imagining that medical history is available in this CPRD data set, but not always when a new patient visits a doctor. And then socioeconomic status is a variable that is often important in confounding adjustment, but often undesirable for use as a predictor in a model for ethical reasons. And then based on these variables, we predicted outcomes under each of the 4 intervention options for all patients in the data, using each of the causal prediction methods that I just showed on the previous slide. And we estimated corresponding effective sample sizes. So we have a lot of results, but I'll focus only on a small selection of them. First, going back to our example of the individual patient for whom we want to give a prediction under each intervention option with corresponding effective sample sizes. So filling in the numbers here, we're looking at a 50-year-old woman who is using antihypertensive medication and NSAIDs, but no other medications. And then we can predict her probability of sufficient blood glucose control within 1 year after initiating each of these 4 potential add-on treatments. And we can see that, for example, so this is for one, by the way, one of the causal prediction methods, so G computation with sandwich variance estimates. And we can see that for the SGLT2 inhibitor add-on treatment, her probability of blood glucose control within a year is the best or the highest. However, this is effectively based on a much smaller number of people than, for example, the predicted probability of blood glucose control under no add-on treatment, which is a much larger number. And this also reflects the data, because in the data by far the majority of patients did not start any add-on treatment after they did become eligible for this. And yeah, only a minority started one of the potential add-on medications. And then as a sort of prototype of how we think these numbers might be communicated, is something like, if we start SGLT2 medication now, there's a 37% chance that your blood glucose will be sufficiently lowered within a year. And then we can add that this number is effectively based on 64 people like you, meaning with similar age, gender, and medication use. And then again, we're not fully sure of the correct phrasing here, but we might add something like the treatment groups were also comparable regarding their medical history and socioeconomic status. This is on an individual level. And we currently have an interview study planned to evaluate how users of prediction models value this additional information. And in this study, we will interview patients with type 2 diabetes, their informal caregivers, and also clinicians who treat patients with type 2 diabetes. We plan to present fictional cases of patient-clinician interactions, including our causal effective sample size prototype that I just showed. And we will evaluate the acceptability, usability, perceived trustworthiness of this information and its role in any treatment decisions. And we also plan to do what's called a treatment trade-off method, where essentially it's the same as the example with the 2 restaurants that I showed previously, where we first start out with the one having a 5-star review and the other having a 4-star review based on the same number of reviews. And then we start decreasing the number of reviews that the 5-star restaurant is based on. And we see at which point the person might prefer the more certainty 4-star review essentially over the less certainty 5-star review. And so we've been quite busy writing a protocol for this. It's been approved, and we're starting recruitment soon. So that's on the communication side. Then I guess for, us statisticians, I don't know everyone's background, but there is more we can learn from the effective sample size distributions in this case study data set. So here I show an example of the distribution of predicted probabilities of blood glucose control under each of the 4 possible add-on treatments, again for one of the causal prediction methods. And here on the right, I've shown the distribution of effective sample sizes for each of these possible treatments. And firstly, what we see is that the treatment frequency in the general data set is reflected in the effective sample sizes. As I mentioned previously, the majority of patients did not receive any add-on treatments, and we see that generally the effective sample sizes for predictions under no add-on are higher than the predictions under one of the add-on medications. And also we see notable between patient variation in effective sample sizes. This is most pronounced for the no add-on treatment, of course, but it's also still present for the others, as I think an effective sample size of 6 is very different from 100 still. And then another thing to note from the distributions in the case study data is that confounding adjustment, while we think it decreases bias, and we want to do it because we want to adjust for confounding and get better estimates, it can and does increase variance of the estimates. So here I show again the distribution of effective sample sizes for treatment options. And then the red distribution are effective sample sizes for a logistic regression on the predictors without any reweighting for the confounders in L star. And the blue or greenish blue ones are for a logistic regression on the predictors X with confounding adjustment by reweighting for L star. And we can see that the distribution of effective sample sizes generally is shifted a bit to the left for the method with confounding adjustment compared to the method without confounding adjustment. So there is a sort of bias variance trade-off here, which I think in sort of the prediction field, it's quite accepted that you might trade in some bias for a bit of variance. But in the causal inference field, I think usually there's a sort of hierarchy where first we want to be unbiased, and then the variance sort of comes second. But yeah, I wonder, well, whether we might need to change that perspective a bit. There is another bias variance trade-off, which is related to the causal assumptions, namely the assumption of correct model specification versus the assumption of positivity. Here I've shown essentially a comparison of predictions and effective sample sizes from a very sort of simple causal prediction model, and then that's on the y-axis, and on the x-axis it's the same causal prediction method, but with a much more flexible base model or base learner. And we see that, yes, the predictions are different between these two models. And, well, you can argue about which one is better or more unbiased. But we also see that the effective sample sizes for the predictions based on the simpler model are generally higher than the effective sample sizes based on predictions from the more flexible model. Which is also, I guess, a classic bias variance trade-off. But here it relates to the assumptions going into the causal methods. So on the methodological side, we still would like to further explore variance estimation for doubly robust causal prediction methods, and in particular this iLearner that I mentioned previously. And that, includes also variance estimation for machine learning-based causal learners. Since, in previous work, we've shown that the non-parametric bootstrap does not always provide valid estimates of prediction variance for tree and graph-based models. And there we did a sort of parametric bootstrap alternative, which seemed to work better. And we would like to figure out how to do that in this causal setting as well. We'd like to expand the method to other outcome types and possibly time-varying treatment settings, and also see if we can relate the causal effective sample size to the sample size of sort of ideal target trial. If you use different data to estimate your predictions, how large would that target trial be? Coming to a conclusion, effective sample sizes can be obtained for predictions based on various causal learners. There is where we see a bias variance trade-off in the results from the case study. We can see that there is sort of trade-off between the assumptions of exchangeability and correct model specification versus positivity. We've seen that causal effective sample sizes express sampling uncertainty in predictions under interventions, including that uncertainty that is added by confounding adjustment steps. However, the effective sample size does not cover all sources of uncertainty. So for example, there's still freedom in the modeling procedure. There could be measurement error. There could be heterogeneity between settings, which are not reflected in the effective sample size, of course. And so the communication of causal effective sample sizes may help to evaluate uncertainty for causal predictions on an individual level, and to evaluate the positivity assumption on an individual level as well. And possibly even enable a discussion on conditional exchangeability. Of course, this is still what we are trying to investigate in our interview study, but we really hope that in the end, this might improve the transparency of decision support tools based on causal predictions. So that's it from my end. I'd be happy to take any questions and discuss with you. Thanks.
Thank you, Doranne. I can see we've already got a hand up online. So, Alexander, do you want to unmute yourself and can ask a question?
Yep. Thank you very much for the talk. It was really interesting run through. It strikes me it's very similar to an idea. I don't know if you've heard of something called the equivalent binomial count.
I have not.
It's a similar sort of thing, but it's basically the idea that with a binomial count, you have a representation. It's an imprecise representation, so it would represent a set of beta distributions that would bound the distribution that you're trying to communicate, and then you would effectively say you would find the sample size required to convey the uncertainty in what you're trying to get across to the patient. You would say, like, okay, we would expect for every 10 patients like you, we would expect 4 of them to respond to this treatment or something.
Right.
With the idea that communicating natural frequencies is a more intuitive way of understanding things like this. And they did it was in like 2017. They did a study looking at something very similar to your the treatment trade-off method you mentioned. It goes down very well. I can't remember the exact outcome of the study, but I know it was a good way of this method of conveying things in terms of frequencies rather than trying to talk about purely probabilities is a really good way of getting information across. And I don't know to what extent it might help thinking about trying to bound the distribution rather than representing it with an individual distribution, but just another way of trying to deal with handling the variance.
Yeah, well, thank you very much. I'll definitely look into this. I was not aware of this concept, but it sounds indeed related. And it's also, there's also research in the field of risk communication that also about using natural frequencies versus probabilities or intervals of probabilities, for example, which partly motivated this work as well. So it's good to know. Thank you for the comment.
Yeah, thank you very much for the presentation.
Richard?
Doranne, that was such a good talk. Thank you so much. I've obviously heard you speak about this a few times. Every time I listen to you, I learn something new. I really like your future study that you're looking at, where you're speaking to patients about it, trying to get some feedback about how they think this works and how we can use this. So just keep going. It's really important what you're doing. Wanted to ask you a few questions. One of which links to the previous one. So, where does this fit in terms of replacing or not replacing uncertainty intervals themselves? So, for example, let's say you told me that my effective sample size was 40 and my risk was 0.2. How does that help me over and above you simply telling me that an uncertainty interval for me is between 0.1 and 0.35 or something? I'm just trying to understand is it complementary to that, or would you replace it, or maybe your patient group will tell you the answer?
Yeah, I think it's that the final option that you said. So of course we are aware that intervals also exist as an expression of uncertainty. So well, I think one challenge is even to get these type of intervals for certain prediction methods. So whether you in the end translate uncertainty into an interval or an effective sample size, you first need to quantify it somehow or estimate it. And that's already a challenge in itself. But then indeed, once you have, then yeah, it's the question, which one is most useful to people? And interestingly, yeah, when we speak to patients or clinicians about this, they usually are quite interested in this number representation as a number of people like you. Whereas when we speak to statisticians, they always say, yeah, but just give me a confidence interval. What other information do I need? So this question is still open, and yeah, I'm very curious to hear what the patients and clinicians in our study have to say about this.
Yeah, thank you. And it makes my other question was going to the counterfactual prediction models, which is obviously quite relatively new concept in our field, and something that I struggle with. And seeing the added variability in predictions from a counterfactual prediction model makes me more worried about it. But there's another level of variability, which is how do you know which counterfactual prediction model is right? So if you were to, let's think about it, how would you validate a counterfactual prediction model? Would you still have to make assumptions about something? So it's a tricky one to express uncertainty in any way, isn't it? Because we don't even know what the true confounding model should be. I'm not saying you shouldn't be doing it. What I'm saying is it's a challenging concept to know if we're doing things right.
Yeah, no, that's completely true. And indeed, well, first of all, I would like to everyone who is interested in this look up the work of my colleague Nan van Geloven, who has been doing a lot of work on indeed evaluation and validation of counterfactual prediction models. And indeed, to validate such a model, you need again assumptions on the confounding mechanism in the validation data set. So that is true. Yeah, so it's true, but I think especially if you do use the models for treatment decisions and you know that there's this sort of treatment predicted outcome feedback loop, then you also know that if you are not doing these methods, then you're also, there's also a chance that you're very much off. So you can, then it's sort of, it creates this feeling of safety that you're able to validate your prediction in a data set. But yeah, that's great. But then you still don't know if your treatment actually, or if your prediction model actually works in the way you want it to when you're using it for the treatment decision. So yeah, it again, a trade-off is definitely there. But yeah, your concerns are, of course, very valid.
So we're sort of stuck between we're wrong, but we're precise.
Yeah.
And we're probably right, but we don't quite know. Is it?
Yeah.
This will keep you busy for a while, this topic.
Yeah. Yes. Well, I enjoy it, so I don't mind. But yes, indeed.
I'll let someone else ask.
Do we have another question online? Sorry, there's a comment in the chat. If you want to...
It's just me saying the same thing again.
Oh, okay, sorry. Okay, do we have any more questions in the room? So I've just had a question. So I was wondering just about how you envision, how you see this being implemented in practice. So do you imagine that if a doctor has the input in the values into the system and it comes up with your effective sample size, or is it more likely you think it would come up with the entire phrase of how you think this should be worded to the patients? I guess some of this might be what you discuss in your with your patient groups. But I was also wondering as well whether there might need to be any more training towards the clinicians who are likely to be using these as well.
Yeah, I think, well, that's also why we are considering clinicians as an important group of end users of models in our study, because I think first, they are the ones communicating this information with the patients. So first of all, we need to also know whether they want to communicate this type of information, also how they are using it to form their own opinion or recommendation. So yeah, it's definitely, I don't really have a clear answer to your question yet, because that's something that we're still trying to figure out. But I definitely agree that the clinicians are sort of the first port of contact or something, point of contact for this information. And then they might also differentiate between patients. I don't know, maybe some patients do want this additional information, maybe others don't. So that's something that we still very much need to figure out what's best there.
Thank you. Sorry. Yeah, Joe?
Thanks for your seminar. It was great. I just had a thought on what Becky was saying, and you mentioned about training and using it. I was just wondering whether you thought about, not to put a threshold on it, but at what point it's useful. Yeah. So I can see the use in an effective sample size of 2, because it would obviously be bad, and I'd be saying, well, this is bad for me to make a decision based on this. But after a certain point, the effective end, is it useful? I don't know. Yeah. I've thought about it.
Yeah, no, and this is also a question that we've gotten before, and from various audiences, also, for example, from clinicians, sort of what would be a minimum effective sample size for me to still trust this prediction or not. So I think it's a very important point, and I also agree, of course I care between an effective sample size of 5 versus 100, but 100 versus 105, as a patient, I wouldn't care. So, and also as a statistician, I probably wouldn't care. That's definitely something we need to consider. It's just since people differ in their risk averseness, or how much uncertainty they are prepared to accept. I don't know if we can really have a cutoff that would be good for everyone, but maybe from a statistical point of view, we could say something about what is really too small of an effective sample size for a prediction to be useful. Good point, and I agree with you there.
So I think this is a great report, especially when we're moving into an era of shared decision making. But my question was to do with you were talking about sort of different treatments and different treatment add-ons. And this is great if every treatment costs the same or has like the same, sort of implications on healthcare. But if this at the moment, it looks like this model doesn't have any sort of adjustments for costs, or isn't really a consideration of cost to patients, but maybe it is for clinicians or for healthcare implications. I was just wondering whether that had been a consideration part of your research, or whether that was sort of beyond the scope of this, or sort of future research you're thinking of doing.
Yes, I agree with you. So far, it's not been part of our research. It's not part of the explicit modeling aspect. Indeed, so far we've just been focused on predicting risk or a good outcome. We have always tried to place it in context more in the way of saying, okay, if an effective sample size is quite low, then people may upweight other sources of information in their decision. So let's say if there is a probability that it will help, but we're not very sure, then maybe you will consider, it's quite inconvenient to take this treatment and it costs a lot, etc. versus if you're very sure that the treatment will help you. But perhaps these other aspects should also be taken into account more formally in the numbers, let's say. So far we haven't done that yet, but we do always sort of acknowledge that there are other inputs that go into a decision than just the expected risk or benefits.
Thank you.
Thank you. Have you got any other questions, Joe?
Sure. So I've worked in non-randomized studies back in about 25 years ago, where people in the journal, the New England Journal, were sort of claiming that non-randomized studies were as good as randomized studies, and everybody wasn't happy about it afterwards. And there's lots of evidence which show that that was not true. And I guess 25 years, my brain is still thinking. Actually, I'm still a skeptic about what are those assumptions. So your slide 13 gave a long list of assumptions, some of which you have on this slide. How carefully have you gone through all of those assumptions and found some evidence to show that they are, it's sensible to make those assumptions? Because there's a bit of a habit in the world of causal things saying, well, we'll make these assumptions and now we'll just carry on without really thinking about it. But those assumptions are critical to actually the conclusions.
Yes, they are. And we had a meeting with the Stratos initiative last year, where we also discussed a lot about this, because indeed in the causal inference literature, the assumptions also become more and more elaborate and difficult to interpret. But then if you can make those assumptions, then we can derive all kinds of nice mathematical results. But it can become increasingly difficult to translate those assumptions into an example of what it would mean for them to be violated in the setting that you're working in. So it's I think an important topic in the field of causal inference. It's not necessarily the focus of this work, but I do agree that it's important, and we want to also contribute to the evaluation of these assumptions, and not just on the level of the modeler, sort of on the overall level, but also on an individual level, because especially, for example, the positivity assumption is really about all different sort of profiles of patients being sufficiently represented. And so there can be certain profiles that are not sufficiently represented, so for which this assumption may be very unlikely to hold, and other profiles for which it may be more likely to hold. So we're also trying to kind of bring that evaluation a bit more to the individual level. But yeah, for especially an assumption like no interference and consistency, that's really something that you can't really evaluate based on the data. You have to do it based on expert knowledge. And I think it's very important there for the modelers to translate the assumption from a sort of theoretical concept to what it would mean in the context of that study for that assumption to be violated. And then it becomes easier for clinicians or other researchers involved to help you judge whether that is plausible or not. That's my view on it.
That was very nice. That was very nicely described about that. But it seems like, in our world of causal models, where everybody is sending us causal models about one every 10 minutes, that nobody is doing that assessment of the assumptions. The language of the assumptions, as you sort of carefully described, they're technical.
Yes.
And I think we sort of have a duty as statisticians to help people to understand what they are, and to say whether we can check them or whether we can't check them, because a lot of the time we can't. And I think it's, that is part of our sort of, in our strengths and limitations of every paper. We should be having a list of these. Have we done this, this, and this? Because we can identify them. We need to describe them, and then we can see whether or not they can be tested. Nobody seems to do that.
Yes, I agree. Well, I think it indeed could be indeed done better and more explicitly, but I think the same holds for the sort of regular prediction field, where also often decisions are made, for example, excluding patients who died before the outcome could be observed, or these types of decisions are also made, and they also have an effect on the interpretation of the result. And I think that's one good thing that comes from this causal inference idea, is that you do need to be explicit on like which assumption you're actually making when you're making that choice in an analysis, and what the effect is on the interpretation of your results. So I think in general that's important. But I also indeed agree that in the causal inference world, we have a duty to translate these assumptions to the specific context to enable their evaluation in a more careful way.
Thank you, Sean. Okay, do we have any final questions online or in the room? No, don't think so. Okay, so just before we finish, just to say that we do have another TAP seminar booked in on the 10th of March at 1 p.m. again. So we will be joined by Dr. Glenn Martin from the University of Manchester. And Glenn is going to be talking about missing data, so as the missing component in guidance for developing, validating and implementing prediction models. So please do join us for that talk if you can. For those of you on the mailing list, I will send out an invite shortly for that seminar. Otherwise, if you are interested in attending, then please do send me a message. So before we finish, please can we all thank Doranne again for that really interesting seminar.